Good morning, everyone. It gives me great pleasure to welcome you to this imaging session of the 19th session of the annual Cancer Symposium of Shaukat Memorial Cancer Hospital and Research Center. I'm Dr. Kashi Sadiq, working as a consultant radiologist at Shaukat Memorial Cancer Hospital and Research Center. I will be moderating this session. There are some excellent talks coming up in this session. I'm going to introduce my chairperson of this meeting. It's Brigadier Tariq Mahmood. He's currently working as Professor of Radiology at Combined Military Hospital, Lahore. He graduated from Lamikbal Medical College and did his DMRD in 1989. He did his FCPS from the College of Physicians and Surgeons of Pakistan in 2002. He served in Army for 33 years. He commanded the Armed Forces Institute of Radiology, Rawalpindi, and retired as Brigadier in Army. I welcome you, sir. It's a great honor to have you in this session. I'm going to introduce my first speaker of this talk. We are privileged to have Dr. Nadia Mahmood from USA as a first speaker. Dr. Nadia graduated from USA in 2003 in diagnostic radiology from Michigan. She did her fellowship in pediatric radiology from the Texas Children's Hospital in 2009. Dr. Nadia Mahmood got her certification of added qualification in pediatric radiology in 2013. She's working as Associate Director of Radiology Education and is involved in education of medical education of students, the radiology residents and fellows. Currently, Dr. Nadia is working as Section Chief of Ultrasound 6 2016. She is also the Vice Chair of the Pediatric Ultrasound Community of the American Institute of Ultrasound Medicine and will become Chair of the committee in 2021. Dr. Nadia Mahmood is going to talk about the applications of CT PET today and tomorrow. Can you please share your screen, Dr. Nadia Mahmood?
Yes, I will. Thank you so much. Assalamu alaikum, everybody.
Yes.
Good, thank you. Assalamu alaikum, everybody. Sorry for that. So today we're going to be speaking on advances in PET CT and some nuclear medicine imaging. It's a pleasure to be here at Shaukat Khanum, and I'll give you a little bit about myself because I have a history. I have no disclosures. I came to Shaukat Khanum in 1997. I couldn't find a picture when I had finished college, but it was the year that Princess Diana was here. And unfortunately, she passed away that year. And when I was visiting Shaukat Khanum as a college student volunteering, Prime Minister Khan had to leave, unfortunately, to go to her funeral, which was a sad time. I remember being at the hospital. I have a very personal relationship with Shaukat Khanum. I was also there, you can see, in 2020, teaching the fabulous radiology residents right before the pandemic hit. So I was very happy to be in Pakistan before that. But my passion with Shaukat Khanum and in pediatric oncology imaging is because I had Hodgkin's lymphoma at 16. And subsequent to that, after I recovered from Hodgkin's, that's when I did my volunteer work with Shaukat Khanum. Then a couple years later, I developed thyroid cancer and very early breast cancer secondary to radiation effects as a child. So my personal experience of having spent a lot of my time in a children's hospital, as well as being a pediatric radiologist, has really made me love this institution. So thank you so much, and it's an honor to be here. So a little bit about our department. This is our nuclear medicine department at Texas Children's. You can see like your beautiful pediatric ward I saw at Shaukat Khanum. It's very colorful. It's really important for the kids to have this. We have them they have their own control, so they can go into the room themselves and they have the choice to go and choose whatever theme they want. The room will light up to that color. Different musics and sounds will play, so it's really important. This was our first PET MRI, which I'll briefly speak on. That we got back in 2013. So a little bit about PET CT. What is it? Why is it so confusing? All these words are often thrown around at us, but really PET is a type of imaging technology to really evaluate how your tissues and organs work at the cellular level. We're going to talk a little bit about the common indications for PET and what you all may see here. Oncologically-wise, obviously there's great neuro-onc applications. We do a lot with lymphoma. You'll notice my talk today has a focus on lymphoma. We do a lot of imaging for neuroblastoma, not necessarily with PET, but with MIBG, but there are some indications for PET we'll talk about. We do a lot of sarcoma imaging, and we have a very huge population of Langerhans cell histiocytosis. Dr. Ken McLean is one of the world's guru, and he brings patients, not only pediatrics, but I see 80-year-olds, 70-year-olds coming from all over the world, Africa, et cetera. And I do rounds with him every Thursday. So we do a lymphoma LCH conference together. So we do a lot of PET for LCH.
Dr. Nadia, sorry to interrupt you.
Yeah.
Can you please make your screen a bit bigger? It's coming in a vertical layout.
Oh, really?
I can see, we can see the single screen, but it's in a vertical layout.
Wow. I've never had that problem. I was practicing early today. Display settings.
Yeah, we can see all your slides, but it would be
Can you
more
see my
easier.
arrow? Can you see my arrow?
Yeah. We can see the scrolling, the screens are scrolling, but it's in the vertical layout.
That's very strange. Display setting. Let me see if there's anything else I can do. Has anyone had this problem before? Know how to fix that? Because I've never had that issue.
Yeah, if you can't, we can continue it. We can see your screens. It's
Oh,
just
no.
it's not zoomed up.
Okay. I wonder if I can do it another way. Let me try something else. Yeah, I practiced at work today and they said that they were able to see it okay. Is that any better or no?
Yeah, it's better than before.
Yeah, it's not in the regular view that you normally see.
Yeah.
Right? Or
Yeah.
is that better? Do you prefer this or shall I go back?
I think it's better. You can start. You go back to where you stop.
Okay. Oh my God, now it's going to be hard to click. Okay, we'll try to do this. Anyway, so some non-oncologic imaging that we also do at Texas Children's is epilepsy. We do some child abuse imaging using PET, and recently congenital hyperinsulinemia, infection, inflammation, things like that. So we know that PET is very good for both, not just anatomy, but for anatomy and physiology. Sometimes if you just look at the anatomy, you can be like, where's the tumor? And that's why we need PET, and that's why we need that fusion to be able to localize this metabolically active tumor. So it's excellent to combine PET CT or PET MRI, whatever you have at your institution, to do that. So here we're looking at different sources, and you can see that with medical imaging, you're really just looking at the biological tissues, but with nuclear imaging, we're internally giving a radiopharmaceutical, and then we're recording the distribution of that radioactive material in time and space. So there's two detectors on either side of the patient, and the radioactive material is going down. This is not going to work as good because all my arrows aren't working, but we'll make the best of it. Think of SPECT and PET like AM and FM radio frequency stations. Sometimes it's confusing, just like ultrasound and MRI or ultrasound and CT are two different modalities, so is this. It's just that the SPECT and PET, they have different energies, so we use different detectors tuned into those different energies to detect and to form the pictures. So just like we listen to a radio, either AM or FM, it's the same thing with SPECT and PET. They're very similar, but we're just kind of fine-tuning their different energies to interpret that picture. So just a little bit more about PET since we're speaking of that today. The radioisotope or the radioisotope we use, which you've heard of, FDG, has a very short half-life compared to many of the nuclear medicine isotopes, which makes it an excellent isotope for medical imaging. And so what happens here, it's very simple. Through the process of decay, it emits a positron. Once the positron hits the electron, it emits two photons in opposite directions. And the way we detect or make an image is that we have this ring of detectors, as you can see here, going around the patient. Once you have that, a 3D dimensional image of the organ emitting the photon pair is able to be made. So that's a little bit too much physics, but sorry for that. You have to do that. So what is good about PET? Well, I'm not showing you these because these are the most beautiful images in the world, but I want you to be able to see that with a PET scan, you can image in multiple different planes and you can fuse it in multiple planes. So here we just have a coronal PET scan. This is a fused PET CT scan. Here's just an axial kind of raw image, but look how much prettier that axial image of the brain gets when you combine it either with a CT or MRI. So it's functional imaging combined with MR imaging or anatomical imaging in multiple different planes, which makes PET so nice and easy for us to use. We know that back in the early kind of 2000s when PET really took off, it really changed the management in up to 36% of patients. It helped us make biopsy decisions, treatment decisions, whether we should wait, whether we should go back in, should we change to radiation, continue with chemotherapy. So it really helped us define goals of treatment and help with our patient care. And this was even more valuable. If you can see the numbers here, up to 91% was the sensitivity when you combined PET CT as opposed to just PET alone. So instead of just having that grainy image, now when you combined a PET and fused it with your CT scan, your detection of metastases was up to 91%. When you exclude small lesions such as those in the lungs that are less than 1 centimeter, the PET CT was up to 89%. So it was actually quite a bit specific as well for looking for lesions, metastases greater than 0.5 centimeters. So excellent, excellent, really changed the way we do things. And you can see these were early on studies just in the United States, even from me being a resident back in 2004 to now, the numbers are even much, much higher now. We hardly have, I've never seen a PET only scanner now. It's almost all diagnostic PET CT, and now the new wave of the future, of course, is digital PET. So the FDA actually has only approved 3 radio tracers, and we're going to talk a little bit about different radio tracers. There's sodium fluoride. Of course, there's FDG PET, which is the most common used one. And the third one we don't really use a lot is flurbetapir. So we're not going to even talk about that one. What you guys need to know when you talk to your patients, for some of the clinicians in the audience, is I'm sure you get the question a lot is, how much radiation exposure am I getting from my exams? Well, it's just simple. I always tell them, in the United States, if you take a transcontinental flight from America to Los Angeles, which is about, or sorry, New York to LA, which is about a 5-hour flight, it's 0.04 millisieverts. And that's about the same as a chest x-ray. So when you take that flight, you're getting the same dose as a chest x-ray. So that's kind of one way I remember, but obviously the higher, the more intricate your modality, the higher radiation dose. So PET CT, the downfall is it's going to have a higher dose than PET, but of course we're doing a low dose CT with that as well. We are at our institution doing diagnostic CTs along with our PET, just so the patient doesn't have to have 2 separate exams. I like to also think of it as an inkjet printer. Sometimes when I'm explaining it to my residents, you have many different inkjets or different colors and cartridges that we put into the machine to provide this functional information or printed out. So sometimes that's an easy way for the residents to remember. And unfortunately, this was a survey from Children's Oncology Group. There was only very small gains in survival for the majority of pediatric malignancies. So when I was treated for my malignancy back in 1992, it doesn't seem like things have evolved a lot or changed. Luckily, I did have, Hodgkin's, one of the most curable ones, you're always told, but we still need to continue studying this and find new novel approaches to how we're going to treat pediatric cancer. So what you guys want to know when you hear FDG all the time? Well, you know that it means 2-fluorodeoxyglucose. All you have to know is that it's a glucose analog and it likes to go to places of high metabolism. So it's an excellent all-purpose radio tracer. And again, that short half-life of 110 minutes makes it very accessible for us. We can order at all times. It's easy to be delivered to us by car or air. So that's why it's really easy as opposed to many other radio tracers, which are less common and harder to find. And again, the vast majority of non-CNS pediatric tumors have increased glucose metabolism, so FDG is an excellent tracer for that. Now, because I'm using this, unfortunately, I'm not going to be able to have my fancy animations. But limitations of PET, it's not reliable for small lesion detection, as I mentioned. There's a lot of physiologic uptake in the thymus, the gastrointestinal tract, normal lymphoid tissue, basically everything I'm showing you here. So this is normal brown fat activity. And a lot of patients or people who aren't very familiar with pediatric PET come over to us and they're falsely giving me a lot of false positive signals, lymphadenopathy in the neck and chest, but often I go in and I realize it's a lot of brown fat. So remember, you can have brown fat uptake in the neck, the supraclavicular regions, all the way down the spine, even in the perinephric region. So that's just common. We all know that brown fat is more common in young children's, kind of the thinner young females. You can reduce the warming or reduce the shivering of a child, putting them in a warming room, which we do for about 80 minutes. But our institution, we don't routinely give beta blockers or fentanyl or any drugs to calm the patient down. We just like to keep them warm. So the importance of PET tumor imaging, the paradigm really is it's the first test in diagnosis because it confirms tumor uptake. It shows you all the sites of disease. You can measure the metabolic activity by measuring the SUVs. So basically it's a staging exam. And then you can go ahead and look for the best site of biopsy. Do you want to do an inguinal node? Are you going to go into the mediastinum, the axilla, where have you? It's excellent for follow-up imaging because we're following the SUV activity of these metabolic lesions. And of course, it's an end of therapy exam to make sure that we don't need any further treatment. more cycles of chemo, radiation, etc. And again, after completion of therapy for, survivors like myself, do we still need it just to monitor for recurrence later in life? Lymphoma, again, lymphoma is excellent for PET because it's just very FDG avid. It really takes it up, and the beauty of it is what I teach my resident is it just melts away after a few cycles of chemotherapy. CT and MR can sometimes underestimate tumor response to chemo and radiation, so it's really important to do a PET scan to follow up in intervals and to see how that patient is doing. And this is a perfect example. This is one of our 17-year-olds with Hodgkin's lymphoma. This was status post cycles of 2 chemotherapies. So look in the beginning when she came in, almost exactly a year ago from today. She had multiple enlarged mediastinal nodes. There's a big soft tissue mass. There's almost this pericardial stuff. Is that effusion? Is it soft tissue density? She has huge axillary lymph nodes, and there's all this mediastinal adenopathy. Here's all the PET scan just lighting up everywhere. And then it beautifully, just 1 month later, it just seems to melt away. So lymphoma really, really does great with chemo. And of course, PET is really good to image it. Here's another example how you can see how PET offers improved response based on this approach to our new treatment regimen. This is a patient just 2 months apart. The first image is in June. The second one is in July. So they're about 6 weeks apart here. This large anterior mediastinal mass was very PET avid, and you had some supraclavicular and some cervical lymphadenopathy. You can see that there's multiple sites of disease in the neck and chest, not just what we're showing here. And I wonder if there's something here as well. So possibly supra and infradiaphragmatic disease, and look again how nice that clears up. This is just normal uptake in the heart, in the collecting system, in the bladder. So in a very nice response. You still have some physiologic thymic activity. You can have some rebound thymic hyperplasia, and that can show up to 6 months, sometimes after disease. Let's have my clock going. Okay, so when do we do bone scans? Well, bone scans are not routinely done in Hodgkin's disease patients, only those with bone pain who have increased alkaline phosphatase or other extranodal sites of disease. So we don't routinely do it for Hodgkin's. We do bone scans, of course, for our sarcoma patients, Ewing sarcoma, osteosarcomas, clear cell sarcomas, any other of the sarcomas, they're going to get a bone scan. And sometimes it depends on the pathology if they get a PET scan. But of course, we don't do gallium PETs anymore. We know that a PET scan is much more sensitive in detection of nodal disease, and it's excellent for evaluating the spleen. Not as good as the marrow. You can't get definite anatomy with PET scan because an MRI or a PET MRI combined would give you better information about marrow disease. So I like it for the spleen and of course all the extranodal sites. Some of the pitfalls we talked about besides the excess brown fat activity, you can have multiple infectious or inflammatory disorders that can also have increased metabolic uptake, right? So very hot pneumonia, you can be confused. Is that an actual metastases in the lung or is that pneumonia? So that's a pitfall. Kids who've had recent surgery or radiation, sometimes they still have increased activity up to 6 to 8 weeks. So you really have to weed that out. Young kids, because I'm talking about pediatrics, we have a lot of increased uptake in the tonsils, the adenoids, any place where there's a lot of lymphoid tissue in the right lower quadrant around the cecum, the terminal ileum. We get a lot of increased uptake, which is also falsely called disease at times, and can be tricky when we have our kids with Burkitt's lymphoma or PTLD involving the bowel. So again, we mentioned not very highly sensitive for bone marrow. Again, just some other examples of Hodgkin's disease with brown fat and FDG uptake. And again, sometimes you have kids who have very tense muscles and they have increased uptake in their muscles. So that's not abnormal disease. That's just them tensing their muscles. And this is the site of disease right here correlating to that soft tissue mass. Neuroblastoma, again, my animations aren't working, but we do mostly I-123 MIBG for neuroblastoma at our institution. And you can see that neuroblastoma, you don't want to have on an MIBG a lot of osseous disease. Anytime you see any osseous uptake, that's automatically metastases. And I'm showing you this ugly grainy image here because when you just have this, you're really not going to get a lot of information, are you? That's why it's really nice to do a SPECT CT along with your MIBG to look and pick up all these iliac, these spine, these sacral lesions. So it's really nice to combine different modalities. FDG PET is also beneficial in neuroblastoma that weakly accumulates MIBG. Most neuroblastoma really avidly takes up the MIBG, which is a norepinephrine receptor analog. but some of them that don't take it up, you can see this patient, you're not seeing a lot of osseous metastases, but when we did a PET scan, we're seeing a lot of osseous metastases, which is really nice. Here's another example of when MIBG is superior to FDG PET, only in very high-risk neuroblastoma. So in kids who have stage 1 or stage 2 neuroblastoma, you can do a PET scan. However, when they have that high disease, which are the most important kids that we really want to look at, MIBG is kind of weakly avid or non-MIBG avid disease, then you can do a PET scan. But in high-risk patients with neuroblastoma, we still prefer to do an MIBG scan over an FDG PET scan. We do need something better, and that's where we can talk about F-DOPA. This is another tracer, and I'm going to be talking a bit about tracers in the last few minutes. So by targeting catecholamine biosynthesis pathway, that's how we're going to best visualize these neuroendocrine tumors, such as pheochromocytomas and paragangliomas, which are the most common ones we see in the kids. We don't see a lot of the medullary thyroid carcinomas unless they have a MEN syndrome. And it's important because these are transported by amino acid transporters. However, it's not FDA approved, and we've had a lot of hard time finding it in the last few weeks. In the last few months. Our neuroradiologists and neurosurgeons want us to get it back to do some brain imaging, but we recently told them we're having a hard time finding it. It was really nice when we did have it because we could get some really nice osseous lesions. This was a kid with neuroblastoma. Again, we can see that the F-DOPA was showing some of the bony disease better than the FDG was. And it also had a very high sensitivity and specificity. So again, F-DOPA is approved, not FDA approved, but it does show osseous disease well, and I'll show you another indication for that in a bit. For pediatric skeletal imaging with PET scans, sodium fluoride is also very good. This has been FDA approved. It has very high rapid uptake, so you have rapid bone clearance, which means you have beautiful, crisp exams. You can obtain the images less than 1 hour after injection, which is really nice. You don't want our kids waiting a long time around. And you can see here how beautiful these are. And you can see that the sodium PET scan on the left shows skeletal maturation over years. It shows a nice epiphysis. It shows a really just beautiful detail as opposed to your bone scan, which is the run-of-the-mill thing we always do. It's good. It's not as high quality of an image, but it gets the job done in most cases. Dose-wise, of course, the sodium fluoride PET is going to be a little higher than your bone scan, but again, it's risks and benefits. You're getting beautiful images as well. Here's a 61-year-old patient because we have a women's hospital attached. This is one of our patients. This is her bone scan. She had metastatic breast cancer, but look how much more the sodium fluoride is picking up those lesions, even as opposed to an FDG PET. And the difference with FDG PET, if you look at these combined images below, is it's really nicely showing the soft tissue abnormalities better. You're getting all that mediastinal lymphadenopathy, pulmonary nodule. The soft tissue uptake is better with an FDG PET scan. Sodium fluoride is beautiful and still used at a lot of pediatric hospitals to pick up rib fractures with non-accidental trauma. Sometimes it can be very subtle on an X-ray, or even fractures from, metastases. They can be very subtle, difficult on an X-ray. You're going to see it probably on a CT, but sodium fluoride picks those beautifully. I'll just skip that for the interest of time. So this was an 80-year-old female. I'm going to show you some recent cases we had at our institution just to wrap up here. She was a female here for evaluation of hyperinsulinemia, hypoglycemia. So another indication for DOPA PET that I talked about before is hyperinsulinemia in infants and neonates. You can see that when we do this, there's a focal area of increased uptake right in the level of the mid-pancreas, but it didn't really correspond to anything. On this MIP image, this is the normal uptake in the pancreas, but you can tell that this is a little more focal than we would like to see. So this is CHI, or congenital hyperinsulinism of infancy, and the most important thing you need to know is that it's usually in the neonatal period, and it often requires treatment, surgical treatment, when unresponsive to medical therapy, and there's two forms. I just showed you an example of the more rare focal form, which is found in about 40% of kids. And that's a focal adenomatous lesion made of abnormal insulin over-secreting beta cells. So you just have to go in and take out the focal adenoma. They have our PET scan. That will help the surgeons kind of localize a little better. The diffuse form, which is more common, which is just increased uptake throughout the PET or throughout the pancreas, is just due to abnormal insulin secretion throughout the entire pancreas due to all these disseminated abnormal beta cells. And you need a subtotal pancreatectomy for that, unfortunately. So we have been seeing a lot of cases recently at our institution. This was another example of a focal hyperinsulin secreting adenoma. This is a 14-year-old girl with shortness of breath and a murmur. She had a middle mediastinal mass. This is her dotatate PET CT. This is another tracer that we used. I know we're running out of time, so I'll just go through these fast. And this was a paraganglioma. So this is the right upper quadrant mass. Again, a dotatate PET or the dotatate tracer is excellent for not only paragangliomas, but also for neuroblastoma. So this was another case we recently had. And just remember that it captures neuroendocrine tumors that overexpress somatostatin receptors when the tumors are in the body. This was another case of a child. He had a right carotid space mass. We went ahead and did a dotatate PET on him. This is the normal uptake below the head and neck, and this was his abnormal uptake in the skull. And this was a malignant peripheral nerve sheath tumor arising within a neurofibroma. Dr. Kashif, because my stopwatch went off, am I out of time?
Dr. Nadia, you have 1 more minute, please.
I have 1 more minute, yeah.
Yeah.
So I'm just going to show you this last case, and I'm going to skip over the PET MR imaging portion of it. This was a child who had elevated liver enzymes and bilirubin. He had these abnormal hypoechoic densities, which are not very vascular on ultrasound. We went ahead and did an MRI, and you can see in the left lateral lobe, he had this abnormal enhancing kind of soft tissue masses with a few different appearing masses on T2-weighted images that were low signal. So this ended up being a poorly differentiated hepatocellular carcinoma. And the most important thing here is that we did Y90 yttrium treatment. And that is when we go in with the IR and they radioembolize the tumor. So these are images that are done after embolization by the left hepatic artery because the mass or the tumors were in the left hepatic lobe. It's a minimally invasive procedure used in the treatment of liver cancer, and 75 to 95% of patients improve. So you have to do that nuclear medicine scan before. You have to do this to make sure there's no shunting into any other parts of the body. So you do a technetium-labeled MAA scan, make sure there's no more shunting. Then you can go ahead, give the yttrium Y90 little spheres directly into the blood side of the tumor so they become enlarged into the tumor itself. I'm going to cut across the PET MRI stuff, which is not as important, and just tell you that we used to use PET MRI. We don't use it anymore at our institution. And thank you, and I'd like to thank PharmaWise Labs, who is my sponsor, a wonderful institution in Pakistan that's supplying drugs to both Texas Children's and to Shaukat Khanum. So thank you so much, everyone.
Thank you very much, Dr. Nadia.
Thank you.
So our next speaker is Dr. Rajiv Mangla. Dr. Rajiv Mangla is Associate Professor of Radiology at Upstate Medical University in Syracuse, New York. He earned his medical degree and his radiology residency from Postgraduate Institute of Medical Science in India. Then he did his clinical research fellowships in neuroradiology, advanced neuroimaging, and vascular interventional radiology at University of Rochester Medical Center and Strong Memorial Hospital in Rochester. He is certified by American Board of Radiology in both neuroradiology and diagnostic radiology. He's a prolific researcher with more than 40 PubMed publications and more than 100 presentations in international meetings. His primary research interests are advanced imaging techniques and quantitative imaging of brain and spine. So Professor Rajiv Mangla is going to talk about spinal imaging, novel techniques, and recent developments.
Thank you so much. I'm very grateful that for this invitation and opportunity to speak. I will admit that most of the research or or clinical research is mostly in the brain tumors, imaging of the brain tumors, and spine is not my area of research, but you guys gave me this opportunity, and to be honest, I learned a lot. And obviously the experience I had in the diffusion and perfusion imaging in the brain, which we will talking tomorrow in the neuro-oncology talk. And I was very many things I read about the spinal imaging, in the new developments and everything. They are very similar to the brain, but obviously they are not as nicely applied to the spine as in the brain, because with spine, we all know that spine has a very good amount of artifacts. So as the topic given to me, spinal imaging, novel techniques and recent developments, I will mostly cover novel techniques because everybody of us knows spinal imaging, what we do in the spinal imaging, cancer imaging. I will not go into that routine imaging. I will straightforward jump to the to the advanced imaging, and most commonly used imaging is in the vertebral lesions are as we use in brain also. It's diffusion weighted imaging, so from which we can calculate diffusion coefficient, and we can see the cell density, and we can assess the aggressiveness of the tumors, and also see the therapeutic effect after the evaluation. So grossly I will cover all these modalities, and a few other things, when we are talking about the diffusion weighted imaging, I will also cover where we can use this diffusion weighted imaging in cases of imaging in the spine. And as we all know, from the in the radiology department, we always have a good amount of question that whether it's a osteoporotic compression fracture, or it's a assessment of or it's a malignant compression fracture. Or we can also see from the diffusion weighted imaging response to the therapy, we can obviously look for spinal cord infarction, differentiate from the myelitis of the tumor, and we can also see drops metastasis to the spine. I will give you a few examples of each of the imaging methods here, and then we will see we'll move to the next modality. So here is the example of a pediatric case, and as you can see, it is very hard to see on the post contrast imaging this drop metastasis, and you can easily, this is you can easily in the ADC maps and diffusion weighted imaging, you can easily find out the drop metastasis here into the pediatric spine. And so under another example, for the spinal cord infarct, we all know that many times we can be very confused what the lesion is. For example, in this case, it is very difficult to say the lesion, it's just a non-specific T2 hyperintense lesion, and but only good thing about this in this case is you can see the vertebral artery is not looking very healthy. So if you suspect, then you can do the diffusion weighted imaging. Fortunately, nowadays we do diffusion weighted imaging in every case, and we have this facility, we do sagittal plane. This is an example where we did axial weighted diffusion also, and for this dissection, we all know that T1 PET suppressed image is also done, which can see we can see the mural hematoma formation, and and also we can see on the diffusion weighted imaging that there is a area of DWI hyperintensity in the lateral aspect of the spinal cord. So we all know that the diffusion weighted imaging is the key for every answer we are looking for as far as infarct imaging is done. And here another interesting case, we can see that there is a DWI hyperintensity in the vertebral body, and it's a long segment infarct. They are sometimes because they share the blood supply, the spinal cord infarcts are also associated with the vertebral body infarcts, and these infarcts can also show enhancement on post contrast images. This imaging was done about 6 to 7 days after the onset of symptoms, and this was a case of infarction, and it was also involving the vertebral body. As in the brain, we can also use this imaging to see the abscess. Here is a T1 post contrast imaging, which is showing rim enhancing lesion with the diffusion weighted imaging seen here, and we can see that there is restricted diffusion within the lesion, and another case of like, when we have collections formation, particularly like it is very helpful in cases of post-operative collection. This is a like, de novo case, but there was a pre-sacral abscess, and we can see that there is a restricted diffusion, and we could aspirate this abscess, although we had to go through the sacrum. As far as like, a short note, like, this is like, as we all know that spine imaging, diffusion imaging has a lot of challenges, like, for many, many years now, like this sequence, which is like, probably Siemens, but every vendor has come out with this sequence, like, read out segmentation of long echo trains. This is the like very robust sequence as far as diffusion weighted imaging is concerned, and we can obtain like very high resolution images with reduced distortion. As we all know that distortion is a major problem in cases of diffusion weighted imaging, and so what else we can do with the diffusion weighted imaging nowadays, like, we particularly like for all the cases, like, the PET scan is quite widely used, but in cases of myeloma, or also like because MRI is frequently done, like, as in cases of the brain, like, post contrast images are not very helpful in cases of removal of the post contrast images can show still radiation effect or treatment effect, but in these cases the diffusion weighted images can be very useful. Like number one, like, you can use you can see more lesions, like, sometimes these small lesions can be overlooked in cases of diffusion weighted imaging has, like, they are like almost like a PET scan, they can light up. So diffusion, like, and now with the less distortion, with resolve imaging, like we have more capability of picking up these lesions into the spine or like metastasis. And same, like, in the post treatment effect, as we see, like, the diffusion weighted imaging is showing the response, and that the DWI hyperintensity has gone down. And like this is a better example, like we have post contrast images, and like, DWI images is showing this hyperintense lesion. And the most important thing here is the ADC images. And in the ADC images, we can see that there is a dark ADC, which means like the tumor is very highly cellular, and the tumor cellularity is like, is a very active tumor, or very malignant tumor in this case. But when you give the treatment, although it is still showing enhancement, and it is maybe like, DWI hyperintensity is still there, which is like, T2 shine through effect. But we are more concerned with the ADC maps. So ADC maps is very important. Like whenever we, as in brain, whenever we are looking the DWI images, it is very important for us to look for ADC maps, and ADC maps are like, are the real finding. So here, like if we compare from the previous one, the ADC maps has gone, ADC has been facilitated. So facilitation means like, there is a very less cellularity here. It is mostly like, it's a very good response to the treatment. So one of the more nowadays used like is like differentiating benign from malignant vertebral fracture. The concept is same, that in cases of benign fractures, there will be just edema, and in cases of malignant fractures, there will be cellularity. So what happens, like, this is the case of malignant fracture, and what we can see, there is an enhancing lesion, and on DWI images, there is a DWI hyperintensity, and on ADC, so again, ADC is the most important thing. And in ADC maps, like, you can see there is a quite bit of high cellularity within the lesion. So that means this is a metastasis. And if we see on contrary, like, the regular fracture, like osteoporotic or other traumatic fractures, like you can see there is a like not much DWI hyperintensity. And again, we want to emphasize on the ADC maps. on ADC maps, there is a facilitated diffusion. I will just quickly scroll to the previous image where the ADC was dark. As we all know that in all the high cellular cases, particularly if we talk about lymphoma in the brain, lymphoma is characteristically bright and dark on ADC maps. So that's why these maps are very important, and we can see that fracture and treatment response. Another thing, this is not very important, but it is very helpful for us in day-to-day imaging, what we call it as a claw sign. I'm not sure what is exactly etiology of this. It is not exactly seen on the ADC maps, but we just recognize it on the, and there was a paper this is paper came in the AJNR about 4 years ago, that this claw sign is very specific for modic type 1 changes, and this and we always have in a practical situation that these type of changes modic type changes versus osteomyelitis, early changes of osteomyelitis, and many times it is we have been fooled, we call it early modic changes, and it turned out to be osteomyelitis, and it is a very big problem here, because then it's a lawsuit, we missed a osteomyelitis, and the paper later on patient comes with more deformity, and so although we, and on the other hand we don't want to biopsy a modic type 1 degenerative change, which is which everybody which many people has otherwise, and it should not be biopsied ideally. So this has helped us a lot, the claw sign, and it is on the diffusion weighted imaging. So I thought I will, although it's not very important as far as oncological imaging type of thing, but since it is a diffusion finding, I thought I will put it in a slide here also. So now we are moving to the dynamic contrast enhanced T1 perfusion imaging. I have not much experience in the spine, but I've done quite a bit of the dynamic contrast enhanced and as well as DSC image in the brain, and this has recently came out. I think first paper came out into 2013, and not many institutions are doing I think only 2 or 3 institutions in the United States do it. One of them is Memorial Sloan Kettering, and because the reason for this thing is most of us in the context of imaging, we use still post contrast images as well as PET scan. Those are the methods we use quite a bit, but this can be a very helpful tool. I have worked so far in the brain tumors, and the same indications are here into the spine, and obviously as we see in the brain, we want to differentiate low grade gliomas from the high grade gliomas. Even we want to differentiate between tumor effective demyelination from the real tumors. So same way we are differentiating here benign versus malignant vertebral fractures. We can evaluate tumor response to the radiation therapy, as we saw in diffusion weighted imaging, and we do it in the brain also, quite often. That's what the role is of the perfusion imaging in the brain. And there was one paper which came out we can differentiate between the myeloma and metastatic cancer, although it is not that important, they always end up in the biopsy, and this is and we can also predict some recurrence, and these are the things which we can do. But ultimately the 2 things are most important, that whether how much this is the number 2 is the most important, how the tumor responds to the treatment, and as we know this is dynamic contrast enhanced T1 weighted imaging, and we usually calculate these parameters K trans and VP, plasma volume, and so we are looking for these parameters, and we can these parameters are a little bit difficult, but this is a very simple, and it is also used in the breast imaging. These are simple graphs, and they can be very useful to see the active tumors, like the washout type of thing, like, this is a tumor, there is a sharp rise and then there is a washout. And in cases of treated tumors, like those who are, and they have like, slow rise, and then the contrast remains there. So these type of things, like, are mostly widely available. Like, if we want to use them, the same software can work for the T1 weighted imaging. Like, although the other this type of maps, like, they are very difficult, like, for the sense, like, most of them are like not commercially available softwares. They are like, done in the labs with the SPM type of softwares. So that's what it is, like, and but these are very helpful. Like, if we want to use them, it can be generated with most of the like basic maps, and so what we are doing, like, we have generated, like, this is a lesion in the mid thoracic vertebra, and like we have diffusion weighted imaging. Although there is no ADC is the most important here, but you can see there is a perfusion which is increased, like, K trans and VE plasma VP plasma volume. So these are the things, like, which we can say, like, are increased. And this is after treatment, and after treatment we can see that the diffusion has gone down, and like also the K trans and plasma volume has become very low. So that those are the things, like, and they did, like, the study, and they found, like, that between treatment success and failure, there was a difference. There was more change. In cases of treatment failure, the VP plasma volume remained high, and and in cases of there was a successful treatment, there the plasma volume became very low. So yeah, so this is a thing, like, and also, like, as we saw in diffusion weighted imaging, like we have dynamic contrast enhanced T1 weighted perfusion imaging. We can differentiate between benign and malignant fractures, as we saw in diffusion weighted imaging. The perfusion weighted imaging will also show, like, as expected, like these tumors have neoangiogenesis, and all these tumors, when they form, have these tumors has neoangiogenesis, they can have more plasma volume. They can have, like, these immature vessels are also have leaky, so that's why there is more K trans in these cases. So moving further, we can have, like, we can see, like, the recurrence, and we can this is a study came out in 2015, like, 17, and they have, like, shown that these K trans and plasma volume goes down with the treatment effect, and if this is going down, that means the treatment is working. And now moving to the other modality, like, new technique, this is, like, diffusion tensor imaging and fiber tectography. Again, we do it a lot in cases of brain lesions, very challenging in cases of spine. As all know, like, now we have more hopes that with this resolve technique, and, like, we have as we do in the brain, we have, like, these directional maps. In the directional maps, you can see, like, the spinal cord is shown with the, like, craniocaudal direction. So all the things which are, like, the fibers which are moving, which are, like, descending or ascending, like, in the craniocaudal directions, are given the blue color, and the fibers which are right to left, they can be given green color. So these are, like, directional.
Dr. Mangala, sorry, you have 1 more minute, please.
Oh, I'm so sorry. So yeah. I completely lost it. So, like, we will we will quickly go through the slides, like, we can use them for tumors, and we can use, like, perfusion imaging. Like, perfusion imaging only useful for the cervical, like DSC perfusion, which we use a lot in the brain imaging, but they can be used in the lesion cervicomedullary junction, and we can if we have a, like, another method is chemical shift imaging, and chemical shift imaging is like we do in adrenal adenomas that drop. In this case, this is a benign lesion and the drop. So just to summarize, we have apparent diffusion coefficients, dynamic contrast enhanced imaging. I did not cover intravoxel inherent coherent motion and chemical shift imaging. They can help us to differentiate between the particularly treatment response and to differentiate from the benign to the malignant lesions. Thank you very much.
Thank you, Dr. Mangla. It's really nice to hear from you, particularly regarding the DCE and ADC values role in differentiating from benign and malignant tumors. Thank you very much. So our next speaker is Dr. Kashif Shazli. Dr. Kashif Shazli graduated from DAW graduate in 2002. He did residency training from Ziauddin Hospital in 2008. He finished MCPS and FCPS from the College of Physicians and Surgeons in Pakistan in 2008. He did his fellowship from SKCS in vascular intervention radiology in 2011. He did his FRCR from UK 2015, fellowship from Switzerland in PET CT. He is currently working as chairman of the imaging services of Indus Hospital system of Pakistan, and is also associate professor of radiology. His areas of interest include MRI, CT PET, and vascular intervention radiology. I welcome you, Dr. Kashif, to this session. Dr. Kashif is going to talk about the bone and soft tissue sarcoma imaging, conventional to advanced techniques.
Assalamu alaikum. Kashif, can you hear me?
Yes, we can hear you. Dr. Kashif, please share your screen as well.
Okay. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Kashif and Shaukat Khanum Hospital for inviting me in this great morning to talk about bone and soft tissue sarcoma imaging from conventional to advanced technique. I am working as a chairman radiology services across the network of Indus hospitals. Indus Hospital is actually a charity-based private setup, tertiary care setup, and we have running 14 hospitals across the country, and all of these are free of cost for everyone. Two big hospital setups are being constructed, one in Karachi, which is 15-bedded hospital with all necessary tertiary care facilities, and the other big setup is being constructed in Lahore, which is 600-bedded hospital, and the whole tertiary care setup is cashless, and there is no cash counter in whole system. So it is our pleasure to work there, and there are hundreds and thousands of patients who are visiting every day to our setups. So there is no disclaimer and no disclosure. There's no obvious conflict of interest. My presentation is based on teaching material taken from internet, and there are many cases from our own center. So I have kept my talk very basic because I know there are many residents and junior physicians who are attending this symposium. So to keep things very simple, I have just categorized the sarcomas into basic categories as soft tissue sarcoma and the bone sarcoma. And the modalities, because we are radiologists and we have to teach our colleagues, our juniors and our colleague physicians that how they can wisely use the radiological modalities. So for bone sarcomas, the most important modality to me is a radiograph. And the importance of radiograph is usually underestimated in case of sarcomas or in any malignancy. But many times radiograph depicts much better picture of the bone pathology than any other radiological modality. So for bone sarcomas, radiographs has very important role. Second is ultrasound, and the role of ultrasound is also underestimated among radiologists as well as physicians, because radiographs and ultrasound are usually cheaper than other radiological modalities, so their importance are usually underestimated, but they are very important, especially ultrasound. If we use wisely and in experienced hand, ultrasound can depict many pathologies better than even MRI. It can depict ultrasound, it can depict neurovascular bundles, it can give an idea of vascularity, it can give an idea from where to biopsy the lesion. And in our center, we used to do ultrasound concomitantly with MRI for further characterization of the lesions and especially for the biopsy. At our center, most of the biopsies for sarcomas are being done under ultrasound. Even many mediastinal masses we attempt under ultrasound guidance. CT scan definitely is very important for staging the bone sarcomas, and there are certain criteria which should be kept in mind while reporting sarcoma staging scans. MRI is definitely for the loco-regional extent of the disease, and nuclear scan for bony metastasis. For soft tissue sarcomas, radiographs have no significant role. However, radiograph can be done as an initial investigation, and ultrasound has a primary role, especially if the lesion is present within abdomen or within soft tissues, even in the peripheries. And one important thing to understand is that as the lesion is in the periphery, the ultrasound will do better. And if the lesion is inside the body, deeper seated, ultrasound will have a limited role. So ultrasound is still important, and for biopsy guidance and for to see the imaging characteristic, to see the content of the sarcoma, like whether it has necrotic component, where in the component there is significant vascularity, and where is a suspicious viable tissue in the lesion. So ultrasound is important. CT scan, as usual, is very important, and it's always done with contrast. Similarly, MRI for loco-regional extent of the disease, and to see the skip lesions, to see possible viability of the lesion, especially in the follow-up scans, and nuclear studies for staging. So optimal imaging protocols are very basic. If we talk about radiographs should always be focused on the pathology. Like if the swelling is in tibia, so the tibia should be imaged and focused for radiograph. And remember, one view is no view. There must always be at least two views to depict the pathology, to see its characteristics. So adequate exposure is also recommended, because sometimes inadequate exposure may lead to false impressions. In MRI, the spin equal sequences are basic, including T1 weighted images, T2 weighted images, fat saturated proton density images, or fat saturated T2 weighted images. Short or inversion recovery, all these are required for imaging a sarcoma, whether bony or soft tissue sarcoma. Dynamic contrast enhanced MRI can be used for characterization, but in our setup, we usually do T1 fat sat post-contrast, plain post-contrast single phase study. Gradient echo may be required for lesions where there are suspected susceptibility artifacts or hemocytin deposit, or the lesion, those containing blood products, etc. We also do DWI ADC imaging in all sarcomas, because DWI can depict some areas of interest where we can do biopsy, and the DWI and ADC mapping may also help us to see the viability of the lesion, suspected viability of the lesion on follow-up scans. MR spectroscopy can be used. We usually don't use MRS frequently, but it can be used because almost all malignant lesions, sarcomas, show increased choline peaks. So it may be helpful in follow-up cases. CT scan should always be done with contrast, And optimal windowing is mandatory because tiny pulmonary mats can be missed on soft tissue windows. So maximum intensity projection windowing is recommended to see the micro metastasis and to assess the vascularity of the lesion. All planes should be assessed carefully, especially coronal, sagittal, and axials, and appropriate windowing is recommended. As far as ultrasound is concerned, it should be done with high frequency probe. Color Doppler imaging should be adopted. For evaluation of the peripheral neurovascular bundle, ultrasound is better than MRI. Elastography may be adopted to characterize further the lesion, like it may be benign or it may be malignant. As Nadia elaborated very beautifully, the role of PET CT, it has role in primary diagnosis and follow-up, and it is beyond the scope of my talk. So the best way to know an abnormal is to know normal. So there are various tumor-like conditions which are more frequent than sarcomas. So we, as a radiologist, as a reporting person, we must know all those tumor-like conditions which may make the sarcoma. If you exclude all those conditions, the ultimate residual or remnant entity will be sarcoma. So there are some important points to understand whether to label a pathology, a suspected sarcoma, or less likely a sarcoma. So there are certain questions to be answered whenever we want to report a lesion, like could it be a normal structure? For example, if we see an abnormality, can you see, Kashif, can you see my cursor?
Yes, we can see your cursor, yes.
Okay. So here in this image, we can see a lobulated abnormal signal intensity lesion, which is subcutaneous in location, and it is isointense to adjacent muscle. And it looks like a lesion, but it's actually an accessory muscle, soleus muscle. Similarly, on CT scan, there is a lobulated and fusiform lesion in the subcutaneous area, just adjacent to usual musculature of the posterior compartment of the leg, and it looks like a lesion, but this is an accessory muscle. Similarly, we have to ask ourselves, does it have a fluid signal intensity? We know that most of the lesions containing pure fluid are benign. However, the remote possibility of malignancy cannot be excluded, but the presence of fluid is a good sign, and we should consider it as an anti-cancerous sign on MRI or CT imaging. Like here in this ankle MRI, we can see that there is a lobulated fluid containing multiseptated mass in the subcutaneous area, just adjacent to the ankle joint at its lateral aspect. And it has also shown some heterogeneous signal intensity and some minimal peripheral soft tissue. This looks like some lesion, but actually this is a ganglion cyst. Similarly, here we can see a large fluid containing circumscribed lesion along the gluteus muscle, and it has no intracystic soft tissue component. And the patient had history of trauma, and this is actually a moral lavelli lesion, which is a hemolymphatic collection after trauma in subcutaneous soft tissues. Here we can see an intramuscular fluid containing circumscribed lesion, which is an intramuscular cyst. Here below, there are 3 images showing lobulated fluid containing septated subcutaneous lesion just above the acromioclavicular joint, which is communicating probably with the acromioclavicular joint. And this is these are the image from MR arthrogram, and this lobulated lesion is actually a geyser from a phenomenon where the contrast is extravasated subcutaneously to make a tumor-like condition. Here on the right side, we can see a large abnormal signal intensity subcutaneous lesion, which is everting to the distal femur, and it is slight hyperintense on T1 weighted images, heterogeneous on T2 weighted images, showing peripheral post-contrast enhancement and central fluid signal intensity. This was a case of trauma. He was a sportsman, and this was a large hematoma. So fluid signal intensity is a good sign and an anti-malignant sign. Another question is very important. Does it have fat density, fat signal intensity or fat density? Like here we can see a T1 hyperintense lobulated inter and intramuscular lesion, which is showing total fat suppression. So this is likely a lipoma, and there is no underlying area of soft tissue density to suggest any malignant transformation. So fat is a good sign and anti-malignant sign. Here this is a CT scan of a 60-year-old female, and we can see that there is an asymmetrical density along the serratus anterior muscle abutting to the left chest wall, and it is showing some fat density as well. And this asymmetric density is not a tumor or malignant lesion. It is elastofibroma, which is a normal variant, and we can and usually occur in late-aged female patients. This patient come to us, and even his MRI was difficult to perform because of huge right upper limb, and we can see that the whole limb is containing massive accumulation of subcutaneous fat, and muscles are embedded within the large fat beds, and there is associated enlargement of the fingers and the whole upper limb. This was a case of macrodystrophic lipomatosis or neural fibrolipomatous hypertrophy. So this is also a tumor-like condition, and careful examination rule out the possibility of sarcoma. Another important question to answer is, does it have prominent areas of T2 hyposignal intensity on MRI? It is very important sign because T2 hyposignal intensity is also an anti-sarcomatous sign, and it usually represents either crystalline deposition or a calcium containing structure or a bone or some pigments, etc. Here we can see an example that there is a large lobulated soft abnormal signal intensity mass in the right along the right shoulder, and it is also extending into the mediastinum, and it is containing some hypointense signals, and on biopsy it turned out to be a fibroma. Similarly, in knee joint we can see multiple hyposignal intensity bodies. These all are within the joint, and these represent enchondromatosis of the synovium of knee joint. Another example of T2 hyposignal intensity is pigmented velonodular synovitis, and we can see here multiple hypointense abnormal signal intensity intra-articular bodies, and these are corresponding with the pigmented velonodular synovitis. We can also see some calcium deposition in different cases, like in calcium CPPD cases or pseudo-gout, where soft tissue calcifications are represented T2 hyposignal intensities. So T2 hyposignal intensity is another sign of benign lesions rather malignant lesions. Another important question, whether the lesion is located within the joint or adjacent to joint, and most of these lesions are usually benign. Like here we can see a lobulated fluid containing multiseptated intra-articular cyst, This is a ganglionic cyst. Another case where T1 weighted sagittal image is showing a fluid containing lesion within the, which is showing fluid level, and it is confined within the suprapatellar bursa, showing fat signal intensity. It is lipoma arborescens. Here we can see on CT scan a periarticular lobulated soft tissue density, which is eroding the acetobulum, and it is well confined around the joint. The patient had history of prosthesis in the right hip joint, and this is particulate disease or particular disease, which is an inflammatory response to the prosthesis. Similarly, an intra-articular hemangioma, which looks like such a lobulated abnormal signal intensity intra-articular lesion containing fat and mixed signal intensity, may mimic a sarcoma. So most of the lesions which are synovial based or para-articular location are benign but can be malignant. Another important question to answer reporting a sarcoma: is it related to a tendon or a ligament? Most of the lesions along the tendons or within a tendon are benign. However, possibility of malignancy can never be ruled out. Like here, we can see multi-osseal abnormality involving the carpal bones, as well as some synovial proliferation in the wrist joint with presence of a ganglionic cyst or localized fluid collection. This was a case of gout. Similarly, here we can see an intra-articular lobulated abnormal signal intensity lesion, which is showing fat and fat signal intensity as well as some hyposignal intensity. And on biopsy, it turned out to be amyloid arthropathy. We can see here a lobulated widening of the Achilles tendon, which is actually a xanthoma, a typical location of xanthoma. Here on ultrasound, we can see a lesion along the flexor tendon, and this hypoechoic lesion is actually giant cell tumor. Another important question to answer is the lesion is vascular or a vascular malformation? And this question needs to be answered, and it is very important to answer this question. This baby came with a large, rapidly growing abnormality, soft tissue abnormality over her nose, and on ultrasound scanning, it turned out to be an arteriovenous malformation. And similarly, another case, a big soft tissue abnormality with multiple phleboliths and underlying venous lacunae. This was a case of venous malformation. A very rare case of large hypodense mass in the left chest, occupying almost the left pleural cavity with a large ectatic vein, anomalous ectatic vein. This was a case of lymphangioma. So all these questions are very important to answer.
Dr. Shalvi, you have 2 minutes, please.
Okay, I just completing. So and the last question to answer is if the lesion is arising from a nerve. Remember that in peripheries, ultrasound, high resolution ultrasound is better than even MRI, and we can see here an abnormal signal intensity mass along the neurovascular bundle of the anterior vascular compartment, and on ultrasound, it was beautifully depicted arising from a nerve. So it was a peripheral schwannoma. So these are recent these are different categories nowadays used for classification on imaging, like benign tumors, intermediate rarely metastasizing tumor, or malignant tumors. These are four categories, and we can categorize these lesions according to these classes. And this was a revised classification by WHO in 2013, and few new entities were enlisted in the list. So malignant soft tissue sarcomas looks like aggressive looking abnormal signal intensity lesions, and they have mixed signal intensities. They enhance, they infiltrate, they invaginate, they encase, and they can erode the adjacent bones. And all those signs which we already excluded in our questions must be excluded in every case. So last slide, an important one, what radiologist should mention in sarcoma report. The radiologist must precisely localize the lesion, measure it in 3 dimensions, and report the distance of the lesion from the chosen landmark. If there is a distinctive shape, such as elongated or lobulated, it should be reported along with signal intensity. And signal intensity, as I elaborated, is very important. The tissue in which the lesion rises should be specified. Solid or cystic or mixed components should be specified. Signal intensity of a solid or cystic component should also be mentioned. The report should specify abutment, encasement, or infiltration with muscles, nerve, and vascular and osseous tissues. If there is either local invasiveness or a clear plane of separation or pseudocapsule separating the lesion from the adjacent tissue, it should be specified. Localizer images should also be evaluated for abnormality in surrounding tissues like lung, liver, kidney, and other tissues. Don't forget to label whether it looks resectable on imaging or not. Without resectability, without mentioning the resectability, the radiologist's report is useless most of the time for surgeons. The optimal site of surgery or surgical biopsy or imaging guided biopsy, MR should be done prior to biopsy, because biopsy can change the MR signal intensity of the lesion. At least 6 weeks gap is recommended in post-surgery era in follow-up cases. There are some more slides, but due to time constraint, I am ending my presentation here. So jumping to the last slide, the take-home message is imaging and radiologists have pivotal role in sarcoma management. Radiologists must have good understanding of tumor-like and must be excluded before labeling a sarcoma. Histopathology is diagnostic, not the imaging.
Thank you, Dr. Kashif. It's a really wonderful talk. You really beautifully shown some of the excellent cases, particularly the tumor-like conditions, non-cancer conditions that can mimic sarcomas. Thank you very much, sir. So we are going to our last speaker. Our last speaker is Dr. Mubin Chowdhury. Dr. Mubin Chowdhury graduated from Leicester Warwick Medical School, UK in 2006. He completed his specialty training in radiology from Mercy Deanery in UK, followed by a fellowship in abdominal imaging with a special interest in uroradiology. Dr. Mubin is currently working as a consultant radiologist in NHS UK and doing abdominopelvic imaging with a special interest in uroradiology. Dr. Mubin is actively involved in medical education, particularly related to the final fellowship exam of the FRCR. As a course director of FRCR 2B preparatory courses, he has conducted over 20 courses nationwide, and he has trained many students across the nation. We welcome you, Dr. Mubin Chowdhury, to this symposium. You can start now, please.
Assalamu alaikum. Thank you, Dr. Kashif. Thank you to Shaukat for the kind invitation. Today's brief talk will be on the multiparametric MRI of the prostate. And I'll just provide everyone with a brief reminder or a refresher, if you like, on where we're up to at the moment with this. So the objectives would be as follows. We'll have a look at how things began with regards to MRI prostate and its current use in clinical practice. This will be followed by looking at the PIRADS criteria, which is the most common or popular one being used worldwide. I'll discuss a bit about the Likert criteria, which we are seeing more of use in the UK in particular, as well as in Europe, comparing the two, and of course then we can take any questions at the end. So it's been 40 years actually since, around about 40 years since the first clinical study of MRI of the prostate was performed, and I think it's those of us who are reporting MRI prostates and seeing this in clinical practice, things have developed fairly quickly over the last, I would say, 10 years in particular. So the technology that we're using now incorporates the routine T1 and T2 sequences, of course, as well as the dynamic contrast enhanced and diffusion weighted imaging, along with spectroscopy. Needless to say that the image quality has improved quite significantly over the years with improved strength magnets as well as phased array coils. And therefore, this has helped in enabling us to detect the tumors and, of course, therefore help in planning of the treatment, as well as detecting any disease recurrence. Traditionally, what was happening was the diagnosis of prostate cancer was primarily based upon the TRUS guided biopsy, so transrectal ultrasound. Of course, this is still being used worldwide, but what's been found is that this can overdiagnose prostate cancer and therefore overtreatment of perhaps low-grade prostate cancer. So I think this is not without its disadvantages. This is a sequence from some of the earlier studies. So I think we all agree that fortunately things have improved a lot now. This was a T2 weighted sequence from the earlier studies, and it's essentially a very blurry picture. I just want to briefly remind ourselves of the sequences that we're using. So as I mentioned, T1 and T2, diffusion weighted, along with the dynamic contrast enhanced sequences. The order of the way things have evolved is, I think, as I've detailed there. So we find that, interestingly, in some centres in the UK, contrast is still not preferred or thought of to be of value. But I think, certainly from my experience, I would say T2 and diffusion weighted imaging is probably the most helpful. And of course, in equivocal cases, we can then move to using contrast enhanced. But it's I think there is some variation to that. So the two sequences I would say that are most useful are indeed, in my experience and the consensus from speaking to many people, is T2 and diffusion weighted imaging. Spectroscopy's role seems to have diminished over the years. So we can see this case that there are some lesions in the peripheral zone, arrowed, giving us a low or intermediate signal intensity. So that certainly raises some concern as to whether there is any underlying tumor. Something like this would then be correlated with the diffusion weighted sequence, and then that would enable us to make a more confident diagnosis for it and subsequently stage it, which we'll just discuss in a few moments. So very briefly, just reminding ourselves of diffusion weighted imaging and what this incorporates. So as we know, it's essentially the motion of the water molecules in the tissues, which is the physics behind it, I guess. As prostate cancer is demonstrating a greater number of these molecules and destruction of water-rich glandular tissue, so we see that correspond to what we manifest in the diffusion weighted imaging, both on the DWI and the ADC map. So DWI would be bright and ADC hyper-intense. And that would suggest that this is something concerning. Just a few examples there, as mentioned. So ADC map and diffusion weighted imaging. Again, there are some, I would say, variations to this on the type of scanner you're using, the quality of image acquisition. So I think I think this is also somewhat dependent on how well the scan has been performed, as there are cases, many cases, unfortunately, where this may not be, this may not aid us as well as we would like it to. But I'll go on to show some other examples as well. So just a timeline really of events, and it's basically bringing us to where we are today, I think. So yeah, it's something which has shown sort of developed in leaps and bounds, I think is suffice to say, as we can see from this timeline. So I think the gold standard at the moment is the role of the multiparametric MRI. It has a role in the assessment of prostate cancer in several countries, along with the management of the disease from the diagnosis to assessing for any post-recurrence, post-treatment recurrence. In the UK, we have a body known as the National Institute of Healthcare and Clinical Excellence, NICE. You may well have heard of this, and it does support the use of multiparametric MRI in men with positive biopsy findings, in whom we're planning radical treatment or active surveillance is being considered, as well as for those who have a negative cross biopsy and there's a suspicion of prostate cancer. The American College guidelines depict pre-treatment detection, staging, as well as surveillance of prostate cancer, report released in 2013. So I think the aim of PIRADS has been to standardize reporting, and as with any, or rather many other modalities and tumors in particular, I think there have been lots of working groups who have tried to standardize the reporting of that particular disease, so that I think it's a language that we can all understand, and of course clinical colleagues as well. So PIRADS essentially is the prostate imaging reporting and data system. We're currently on version 2.1. This was devised approximately 8 years back, 8 to 9 years ago. It's very objectively based, and it allows technical parameters to be established and therefore to be established, and therefore categorizes and summarizes the risk or suspicion of any significant prostate cancer that the patient may be suffering from. So I think at this moment, it's important to establish what is clinically significant prostate cancer. So the MRI is not taken in its as a single entity. We use the Gleason scoring. So Gleason 7 or more is deemed clinically significant prostate cancer. I'll just touch upon Gleason scoring in the next slide. Volume of more than 0.5 mLs and any extra prostatic disease. So Gleason scoring, very quickly, our pathology colleagues are better placed to explain this than I am perhaps, but basically it's a grade for prostate cancer. If the cancer cells and their growth patterns look very abnormal, 5 is assigned. So the Gleason score is the sum of the two most prevalent patterns, primary and secondary. And 10 would be the maximum score, therefore mentioning the explanation of, as I just have. And these two grades are then essentially added together. So 3 plus 4 would be, most of the tumor is grade 3, and the second most common or most malignant grade is 4. So that's essentially how Gleason scoring is used. Reminding ourselves of PIRADS, so 1 is essentially a normal scan. 2 is significance is unlikely. 3 is quite a large category where you have these patchy changes in the T2 signal intensity, and it's somewhat equivocal, I think, and that's sort of still the way I would certainly use PIRADS 3 personally. I think 4 and 5, we should all be fairly happy with these categories, and that they are fairly convincing of tumor, basically. So I'll just show some examples where we can see these variations, and hopefully that should convince you. So as I mentioned, 1 and 2, essentially, I think within the realms of normal, I think I would call it. 3, somewhat equivocal. You might get some patchy signal change, as we can see from the example shown. And then 4 and 5 are when you have got good going disease. The restriction is very convincingly matching. And the differentiation between the two is essentially on size. So less than 15 mm or 1.5 centimeters would be 4, 5 would be more than 15 millimeters. So I think 4 and 5, hopefully we should all be able to spot with some, I think, confidence, shall I say. Many times we come across 3, and I agree this is an equivocal finding. It's a bit, makes it a bit more tricky. In the center I work at, everybody with PIRADS 3 will be undergoing a biopsy. So I suspect we're putting a lot of people through biopsies because we do come across 3 quite a bit. I've just shown an example of the peripheral zone. This is a transitional zone. Tumors do live here. Makes it more challenging because we know this area contains BPH nodular changes as well. So I think we may have a tendency to overcall in this area because of the changes we are already seeing in what may well be a normal looking prostate, or normal at least, with no cancer. So I think I would certainly use the same principles when looking at the central or transitional zone of the prostate. And we know that the anteriorly based lesions are tricky to diagnose and also tricky to biopsy. So something that's becoming more popular in the UK certainly is Likert. So I think this is a tool which enables more of a assessment which encompasses the clinical and perhaps biochemical parameters, so age of the patient, performance status, PSA levels. I think using PIRADS, we do come across this this information, particularly in the MDT, but Likert has been devised with this in mind, that we would use these parameters, we would have access to them, this information, and we would use it whilst reporting. So there was a consensus last year which sort of rolled out the implementation of this. So I'm seeing more and more centers certainly trying to incorporate this in their practice when scoring. I think some of the issues, I guess, the reason why this has come about is a few problems with PIRADS, a few challenges, is probably the right word, is there aren't any set requirements for ensuring high quality acquisition of images. So as I said before, it seems very much center to center variation as to whether they're doing contrast or indeed just T2 and DWI. It doesn't really standardize the reporting in that it's not giving an indication to the clinician as to whether a lesion is biopsiable or not. And I think based on what I've just shown and mentioned, small tumors could be missed, and PIRADS is essentially reliant upon the imaging findings. So it doesn't really take into account the clinical factors, so comorbidities, age. These aren't things that are taken on board. So I think that in itself proves a bit of a challenge and something we need to be a bit careful of when diagnosing. It's purely based on what we're seeing on the scans. So I think there were a few issues which have come up with PIRADS over the years, and I think Leica has enabled or tried to perhaps rectify these. So just a bit of a comparison very briefly for you. It's more of a incorporating more information, I think, in Leica versus PIRADS. The lesion is more patient or lesion based, rather, should I say, in Leica, whereas in PIRADS we look at that information perhaps secondary to when we've assessed the actual imaging. And then implementation, so Leica would be for detection, active surveillance, recurrence, and postfocal treatment, whereas PIRADS is essentially for being used for detection, detection only. So I think this chart has, the aim of this chart has just been to show comparison between the two and how they differ. So I'll move on to scoring is not dissimilar actually to PIRADS. In fact, I think they probably did use PIRADS criteria when making the scoring. So just in the interest of time, I'll just run through 1 to 5. And obviously 1 again is the presence of clinically significant cancer is unlikely, and 5 being the opposite. So it's not dissimilar to PIRADS based on what we can see from the PIRADS scoring. The research on this is that when comparing the accuracy of different prostatic regions, Leica has shown superiority, particularly in the transition zone. And one thing of interest is that there is greater inter-observer agreement amongst readers compared to, say, PIRADS when they did the study. I think ultimately where PIRADS falls down somewhat is that there isn't any area where clinical and biochemical data can be incorporated within the actual reporting structure, if you like. And I think the benefit of this would be is that we would be limiting the unnecessary biopsies, because I think at the moment, as I mentioned, anything PIRADS 3 and above is being sent for biopsy. So we're probably doing a lot more than we need to be doing. So the study from 2019 validated this and showed that this is a very likely alternative to PIRADS in expert centers, because I think with Leica, based on what I've mentioned, there would be some subjectivity as well. So it really is, I think, once you've gathered enough reporting experience on prostate scans, when I think we can use this confidently. But until then, certainly PIRADS is a means of classification that can and is being used. So I wouldn't completely discount it. Of course, the recommendation would be that expert centers are utilizing this once we've all understood as to what exactly is required. So that brings you to my last slide. I think prostate MRI is somewhat subjective or can be open to subjective interpretation. Hence why guidelines change every few years, and we try and ensure that we're all using a similar or same method or scoring scheme, shall I say. Of course, they are of benefit. They have their merits, as with any tumor staging we would be discussing. But in order to achieve the goals, we need to be consistent. And I think Leica is more of a holistic scoring system. But as I mentioned, it is of course subjective, and it's really perhaps reserved for people with extensive experience. But again, this is something new, so I'm sure in a few years' time, more research will come out, and we'll have a more of an accurate comparison between the currently most popular used PIRADS versus LICAT. Thank you very much. That's a few references I used, if anyone's interested.
Thank you, Dr. Mubin, for such a nice, wonderful talk. We have a few questions at the end. First question is for Dr. Nadia Ahmed. Dr. Waqas has asked about your experience regarding DOTA-PET in undifferentiating neuroblastoma. Should we go for FDG PET or DOTA-PET or MIBG?
I think, I don't know if you guys can see, our oncologists still prefer for undifferentiated, they like FDG PET or MIBG. So we're not doing DOTA-PETs really for neuroblastoma. So I would still do FDG PET or MIBG. And usually for stage 3 and 4, or the higher stages, we like MIBG because it shows it just as well. But I think you can do FDG PET if that's more readily available for you as well, because it's very good for undifferentiated carcinomas as well.
Yep, thank you very much. Dr. Mubin, I have one question for you. Are you doing any abbreviated sequences for screening MR for prostate cancer in your center?
I think screening was or has been trialed, shall I say, in some places, but it's not something which is mainstream. Again, as you know, prostate cancer is the most overdiagnosed cancer. Certainly, we're seeing this in the UK. We have a large elderly population, and I think that it all stems from the fact that we tend to biopsy most people. So, as you know, once you've done the biopsy, you'll be finding some molecular level cancer. So the vast majority of our patients are on a watchful waiting surveillance, so to speak. But screening hasn't, I think based on that reason, screening hasn't quite took off yet, like say, for example, breast screening in the UK. So yeah, it's something which hasn't become mainstream just yet.
No, thank you very much. I have one question for Dr. Shazli that's been asked by one of the audience for the participants. Is there any role of endovascular ultrasound to rule out the neurovascular involvement by the soft tissue sarcomas?
I think endovascular ultrasound is a very good modality, but it has a limited role in staging and loco-regional, and to see the loco-regional invasion of the tumor. I think the conventional high-frequency ultrasound with Doppler is better choice for assessment as well as for targeting the biopsy.
No, thank you very much. And which particular sequence do you think is helpful in excluding the vascular encasement? You're relying more on T1, T2, or post-contrast?
I usually see all sequences in all planes, including spin echo sequences and contrast enhanced sequences, but best are T1 and T2 weighted images as well as stir images.
No, thank you very much. Thank you. So here we conclude our session. I would like to thank all of my worthy speakers for giving such wonderful talks. I would like to thank the chair of this session, Brigadier Tariq Mahmood. I would especially like to thankful to the chair of this symposium, Dr. Sumaira Bhatt, co-chair Dr. Asad Pervez, and our IT and HR team, particularly Ms. Nika, for arranging such a wonderful session in this symposium. Thank you very much.